Let's talk about safe prevention of primary C-section. Some background: maternal mortality in vaginal delivery is 4 out of 100,000 versus C-section 13 out of 100,000. Severe morbidity 1% in vaginal, 3% in C-section. Amniotic fluid embolism 5 out of 100,000 versus 15 out of 100,000. Indications for primary C-section in order of frequency: labor dystocia 35%, abnormal fetal heart tracing 25%, fetal malpresentation 17%, and then multiple gestation, suspected fetal macrosomia. So clinical management questions and answers: management of abnormal first stage labor, prolonged latent phase. We should wait 24 hours or longer for the latent phase, 18 hours plus with rupture of membrane and Pitocin before diagnosing failed induction. Slow but progressive labor in the first stage of labor should not be an indication for C-section. 6 centimeter dilation is considered active phase. Arrest of active phase is 4 hours with adequate contractions and ruptured membrane. Adequate contraction is 200 mounted Medeo units. 6 hours of oxytocin and inadequate contraction and ruptured membrane. So diagnosing first stage failure is 24 hours or longer for wait 24 hours for latent phase, at least 18 hours of ruptured membrane and Pitocin. After 6 centimeters, it's 4 hours with adequate contractions or 6 hours with Pitocin and inadequate contractions. Second stage arrest is 2 hours pushing in a mole tip and 3 hours pushing in a mole tip with epidural, 3 hour pushing in a nullip, or 4 hours pushing in a nullip with epidural. So 2, 3, and then 3, 4. Abnormal fetal heart tracing. We perform neonatal intrauterine resuscitation with however, supplemental oxygen, IV fluid bolus, or tocolytic agents given without indication have limited effectiveness or safety. Induction of labor at 41 weeks is associated with decreased stillbirth. Continuous labor and delivery support, one-on-one support during labor and delivery is associated with improved patient satisfaction and reduction in C-section rate.